Hi, this is Jeff Okeson again at the Orofacial Pain Center, University of Kentucky. And I'm doing this series of lectures on occlusion, TM disorders, and orofacial pain. And the first number of lectures have been looking at more normal function and some of the etiological considerations we have with TM disorders. And we've centered a little more on occlusion because that's part of what we need to know as dentists. And what I want to do on this section is to give you some insights on some of the controversies that we have in the field of dentistry regarding the management of TM disorders as well as just the optimum joint position. And so if we look right here, this is the criteria I left you with last time. They said if somebody asked me what's the most optimum orthopedic stability in the masticatory system, I would say when the condyles are in the most superior anterior position in the fossa, rest against the posterior slopes of the eminence, which is musculoskeletally stable. The discs need to be properly interposed, and then that allows all the teeth to contact, even simultaneous contact, cusp tip to flat surface, posterior teeth a little heavier than the anterior teeth. When the patient moves side to side, the anterior teeth are disengaging the posterior teeth on the working side. And in the upright position, the posterior teeth contact heavier than the anterior. This is orthopedic stability in the masticatory system. Now, although I presented this to you in what I hope was a logical sense, that does not mean that this is not without controversy. In fact, as I have a chance to travel around, I begin to realize that there is a fair bit of controversy. Although we're more than ever, we're centering on some of the basic principles that evidence-based information has presented us. But sometimes there's still controversies. And I say, where's the controversy? What do we think? Well, where's the controversy? Is the controversy in how teeth should occlude? No, not really. All of us pretty much agree on the fact that how teeth should occlude, just as I described it a second ago. There's no controversy there. I have no place that I go that somebody says, oh, I don't want just the back teeth to touch, or the front teeth, or only the right or the left. But the controversy that we're facing right now is in joint position. And it's most interesting as I get to travel around, because a lot of people are talking about positioning of the condyle. And there's a whole group of things that are going on right now. Well, what I've looked at is there are actually 5 different joint positions that we dentists are putting our patients in right now as we try to treat TM disorders or correct occlusion or restore the mouth. 5 different joint positions. And you know what the problem that we're facing is that often when you hear someone talk about a joint position, they're talking about their favorite joint position, and they're not putting in perspective the entire realm of all the other philosophical ideas and controversy. So depending on what course you go to or what book you read, you're going to be endeavored into one different concept and all the others will not be discussed. And I said to myself, you know, that's not really fair. What we need to do is have a situation where we can talk about all 5 of these positions in the same discussion and look and highlight some of the factors about it. So we're going to highlight the review. Let's review some of the literature that might be appropriate for these positions. And sometimes, as you might guess, we don't have sound literature, and so therefore sometimes we have to look at being logical. As much as we would like to have everything we do to be evidence-based, the unfortunate part is we don't have all the evidence, and that's why we develop these different philosophies. So at least, though, if we're going to move into a philosophy without evidence, let's be logical. So here are 5 positions that are talked about right now in dentistry. And what I'd like to do is present to you as unbiased as possible these 5 positions and give you them some support. So if somebody asks me what's my statement of conflict of interest, I think honestly, I really don't have a conflict. I mean, because I don't sell articulators, I'm not selling instruments, I'm not selling ways to do procedures. I have these DVDs, but they're not something that's biasing me. I'm just trying to present the literature as we know it today. And the reason why I'm doing this is not because I'm trying to have some personal gain. It's because I'm looking at patients who continue to suffer. And we have to be looking at our patients because sometimes we are providing care that makes no sense at all, but it's costing patients a lot of money, a lot of their tooth structure, and yet we have no data to support that. So this presentation I'm putting together is a presentation that hopefully has our patients in their best interest. So let's go back to these 5 positions. And I'm going to read them to you. The musculoskeletal stable position, the most posterior retreated position, the anterior protrusive position, a 4-7 radiographic position, and the neuromuscular position. And what I'm going to do is I'm going to take each one of these and I'm going to try to talk about what the data says, who is promoting this, and for what reason. And after we look at all these, we're going to try to put some sense into when you should use one of these positions. And it may be that we'll do part 1 here, and then I'm going to do part 2 and just follow this up, because it may take a little longer than the typical hour that we take in a TBD. So let's start with the musculoskeletal stable position. If you listen to my last lecture, then the lecture that we talked about the musculoskeletal stable position. So what becomes kind of obvious to you is this: if this is my bias, this is what may make the most sense to me. But let's talk about this. What is the musculoskeletal stable position? Okay, it's a position that's stabilized by the muscles that pull across the joint. And we talked about that last time as being an orthopedic principle. So when these muscles are activated, what they're going to do is they're going to let this mandible compress against the cranium, and in that movement, the teeth are going to come in contact, and the condyle will come in a nice, stable relationship. So if we look at this, where's the condyle be going in the musculoskeletal stable position? Likely this position right there, superior anteriorly in the fossa, resting against the posterior slope of the eminence. That's the musculoskeletal stable position. Now, that's the musculoskeletal stable position, superior anteriorly. Now, is this centric relation? I mentioned in the last lecture that I don't always like to use the word centric relation. Not that it's a bad term. The problem is that we don't have the same definition. If you go to the glossary of prosthetic terms and look at centric relation, and the first description you will see talks about a condyle in the most superior anterior position, resting on the thinnest intermediate zone of the disc against the posterior slope of the eminence. That to me is musculoskeletal stable. But centric relation, definition 2, the superior position. Definition 3, the superior posterior position. Definition 4, the most retreated position. Definition 5, uppermost, midmost position. There's a lot of definitions. So if we dentists can't get together on what we call centric relation, then I don't want to use that term, because it means too many things to different people. Okay, so that's number 1, and we've covered that action in the last lecture. So let's skip ahead to the next one, which is the most retreated position of the condyle. For many, many years, we believed that the condyle should be in its most retreated position in the fossa. So what we should be doing with this mandible is push it back, and let it go back against the posterior part of the fossa. Okay, what is this? This is a ligament-determined position. It's not a musculoskeletal stable position, it's a ligament-determined position. Well, how do you say that? It's because when you take a look at the temporomandibular joint, here are some of the structures of the temporomandibular joint, and this right here is the interhorizontal fibers of the temporomandibular joint, and it's the ligament that keeps the condyle from moving too far back. If you remember back in the lecture I gave on anatomy, what do ligaments do? Ligaments hold all joints from moving outside their border. It is the border position. So all ligaments have border positions. All joints have border positions that are determined by their ligaments. And ligaments have a particular length to them. So they'll go so far and stop. That is the border position. It so happens that this is the interhorizontal fibers of the temporomandibular ligament. And what you see with this ligament right here, it keeps that condyle from going too far back. Now, this is a really strong ligament too, because if you fell and hit your chin, you would not see your condyle moving into the middle cranial fossa. What you would see, it would likely fracture right at the anterior, it would likely fracture right here in the neck of the condyle. Okay, that's how strong that is. Now, one of the orthopedic principles that we've already talked about in the second lecture was this: ligaments do not actively participate in the normal function of a joint. They act as guide wires to restrict how far a joint could move, but they don't actively participate within the joint itself during function. I use the example of the cervical spine. You can move your head 90 degrees to the side, but most of your movement is 5 or 10 or 15 degrees, and your head freely floats. Ligaments are not involved. So a basic orthopedic principle is ligaments do not actively participate in the normal function of a joint. And yet, we dentists got this idea that they do, because for a long time, we were started pushing condyles back as far as they would go. And if you push this condyle back as far as it would go, what's going to happen is it's going to move back into this area of the fossa, posterior to the musculoskeletal stable position. So this is a ligamentous position. Is this centric relation? Well, when I was in dental school, this was centric relation. And if my instructor said, put the condyle in centric relation, I had to put this jaw back as far as it would go and hinge it there. Well, you know what? I personally do not believe that makes any orthopedic sense at all, because it's basically saying that this joint is so special, it functions off a ligament, while any other joint in the body does not. So I think that's something that has to be thought of orthopedically. And as we became more orthopedically tuned, we start to realize that concept may not really fit into the joint position. But then the question is, why do we use this position? Why did we even get there in the first place? Well, if we go back into our profession in the United States anyway, and start looking at what we were doing at the turn of the 19th century or 20th century, 1910, 20, 30, we started making a lot of dentures for people. And it didn't take too long to realize that if you just let those patients close, they close here, and one day they close over here, one day they close over here, they close all over. And somebody said, you know, if you push the jaw back, it only goes so far, and you can hinge it there. And if you can hinge it there, something important shows up. You get reproducibility. And if you have reproducibility, then you can take these casts and put everything that's called an articulator, mount those, build yourself some teeth, come back and put them in the mouth, and you know what? They'll be more accurate when they close. And when they're more accurate, there'll be an increase in accuracy, leads to a greater clinical success. So it didn't take long for dentists who were making dentures for patients to realize that this is reproducible and it's much better. They go back, the patient knows exactly how to bite. And so the success rate started to improve when we started using reproducibility. But it wasn't the exact joint position that helped that, it was the reproducibility. Then when in the United States we got into the 40s and the 50s and the 60s, and we started, the gnatologists came on board. And the gnatologists were very precise in reconstructing mouths, not just with dentures now, but the natural dentition. Charlie Stewart made the first fully adjustable articulator. And it had a pantographic tracing. And it could duplicate any mandibular movement. But you had to have a starting point. And so the starting point was what? The terminal hinge. So as everybody's jaw was put back, the patient was rotated at that point, so there was a terminal hinge, and from that point on, all the movements of the condyle could be recorded. And you needed all those movements in a pantographic tracing to adjust your fully adjustable articulator so that the condyle on the articulator will move exactly the way the patient's condyle moves. Now, we thought this terminal hinge was so important and so reliable that we even started putting tattoos on people's faces so that they could always come back to the same hinge axis over and over and over again. Not realizing at that time that in fact skin changes and things change, but we have patients out there who have tattoos on just so they can be placed back onto a pantographic tracing and their terminal hinge can be recorded. Now the concept at that time also was what you might call a point-centric. The point-centric contact basically said that in the terminal hinge movement, all the teeth must hit together, and there must be no slide from the terminal hinge to the intercostal position, and the mandible had to be immediately disengaged by the canine. We talked about canine guidance and canine rise the last lecture. So there was no slide. Everything fit there. Now, everyone started being built in those positions when the prosthodontist was reconstructing the mouth and such like that. And then an interesting thing happened. Dr. Frank Salenza, who was a prosthodontist in New York City, started looking at his patients, and he was developing their occlusion in the most retruded position, no slide. And then he called them back a year later. And everybody knew, we were very convinced that this was always going to stay in the same position, except when Frank Salenza called his patients back 1 year later, almost all of them had a little slide. And the question would be, where did the slide come from? Because if you're in a terminal hinge and that's a permanent position, a stable position, why would there still be a slide? Well, the first answer to that was, well, because Dr. Salenza wasn't a very good prosthodontist and the slide was always there. Well, that's not a good answer because Frank Salenza was an excellent prosthodontist. So another answer might be, well, maybe the teeth shifted in that year, and maybe with the shifting you got a slide. Except at the time that Dr. Slenza was doing this, we were using solder joints and the teeth were all wired together, or all, fused together. The chance of tooth mobility was not very great. But the answer to where the slide came from actually came from data that we already had in our literature. And this is the early work of Harry Lundeen and Charlie Gibbs. And Harry Lundeen and Charlie Gibbs was the very first individuals to develop what's called the replicator, which was the first jaw tracking device that we had. And these are some of the drawings that first came out of that machine. And so he could record everything as a patient open, closed, and chew. And this could be duplicated not only on film like this, but also with patient casts. And if you look carefully at this, this is the normal functioning of the jaw on the working side. The intercuspal position is right near number 1. And as you start to come forward and then back, there is a little bit of movement behind the intercuspal position, which means this is normal to have a little room behind intercuspation. And so when you start looking at this, if we push people back to number 8 here, that wasn't even a range of movement, which means that every condyle, as it starts to chew, there's a little bit of range back here. Now, if the early prosthodontists put their patient back all the way to the retruded position and then reconstructed the mouth there, and then the patient knew exactly how to close, even all the way back here, then what would happen? They would start to close and they would start to chew. And as they started chewing, what would happen? That condyle would have a little bit of movement. It would try to get a little bit of movement. And what we've learned about ligaments is this. You cannot stretch a ligament. We're going to have more to say about this when we talk about intracapsular problems. You can't stretch a ligament because stretching means you pull on it and it goes back. Ligaments don't do that. They're collagenous fibers that if you pull on them long enough, they become longer. They elongate, but they don't go back. Because that's what a ligament does. It elongates. It doesn't stretch. Stretch is like an elastic band. Elongation means it stays at that long length. Which means the more and more they would chew, the more they would take that horizontal fibers of the temporal mandibular ligament and elongate it. Then a year later, if you came back and you push the jaw back, the condyle goes back a little bit further, and you know what happens? The teeth don't fit there. There's a little slide. And that, in fact, was the slide that we saw going on when we used the most retruded position, because that's not how nature built the system. Okay, so that was the most retruded position. What is the anterior-protrusive position? There are some of us in dentistry who believe that the condyle should be be in a more forward position, protruding position in the fossa. So the concept is, what we're going to do is we're going to take this mandible and we're going to bring the jaw forward, bringing the condyle in a more forward position down the posterior slope of the articular eminence. So what position is that? Is that a musculoskeletal stable position? No. Is it a ligament position? No. It's actually a muscle brace position. Because in order to keep your condyle forward, you must brace the muscles that way. Okay, so here's the question. All right, a muscle brace position. It's kind of like saying, all right, my shoulder fits well in this position here, but I think I like it up here. Well, if I constantly hold my shoulder up here and I leave it up there all that time, I'm going to have to get my suit jackets retailored so it fits up here. Well, is that going to increase muscle activity a little bit? Yes, it is, to hold my shoulder up here. Therefore, this muscle brace position is most likely going to produce actually more muscle activity to hold it in this position because it's not musculoskeletally braced. It's just muscle braced. Okay, what's the number one pain complaint that we see from patients? It's really muscle pain. Why would you take a patient and actually activate some muscles more if muscle pain is the most common pain complaint we see in the area of TMD? There's a certain amount of logic here that doesn't seem to fit on that. So what would happen is, in this patient, what you'd see is this condyle, if you believed in this concept, would be brought forward on the posterior slope of the eminence. Not to the full forward position, but someplace forward like that. And that was the concept, bring it forward position. Okay, the question that has to be asked then, does placing the condyle in a forward position cause any anatomical problems? Would this cause some disease, cause an arrangement? And I'd say no, it doesn't. I said because what you're looking at there, when you ask a condyle to come forward, it's still within the functional range, isn't it, of the condyle, of the fossa, excuse me. So you're just having to protrude a little bit. So I would say, well, there's no evidence to say that you're going to abnormally move the disc out of place or whatever, because it's a normal functioning movement. So I'd say there's no anatomical risk factors to produce any kind of disease that way. So this is because it's a functional position. However, the muscles must actively brace the condyle to maintain this position. Therefore, you're going to have a little more muscle activity, which is logical. So the question is, well, what would be the purpose of bringing the mandible forward? Why would we dentists want to do this in the first place? Well, actually, there's several different reasons here, and let's talk about those. One is functional orthodontics. So in a functional orthodontist, what the orthodontist can look for right now is they may find a patient who has a class 2, maybe a short mandible, class 2 angulation, and they're saying this, you know what, if I brought this jaw forward in a growing patient, bring it forward, and then put some kind of an appliance in there to hold them in that position, which we'd call it a functional appliance. Then the hope would be, if I can keep them forward here during growth, maybe we're going to get some growth. And all of a sudden, when you take the appliance out, you're going to have a patient who is a condyle in a musculoskeletal stable position. When they close together, they're going to go from a class 2 to a class 1. So the concept of functional orthodontics is to see if you can encourage growth. To see if you take a patient with a short mandible, get the jaw forward, hold it there, and will that condyle grow more into that fossa? Okay, that's a concept of orthodontics, functional appliances. Now, I know enough from the orthodontic standpoint, there are people who strongly believe that. There are people who do not believe it at all. There's some people who say, you can't make that condyle grow anymore. There's people who say, well, you might get the growth, but you would have got it anyway if you waited some time. And so this is a big controversy in orthodontics. And I'm not here to tell you that this works or doesn't work. You leave that to the orthodontist and let the orthodontist argue about that or not. But I would say this to orthodontists, that if you use this concept, then you have to be careful to make sure you either did or didn't get the growth. Okay, because let's just take this, let's just say you do this in a 10 or a 10, 11, 12-year-old, and you got the mandible forward here like this. But what if the mandible didn't grow? Okay, in other words, if you brought him forward like this, and that mandible didn't grow, something very interesting can happen to the patient. And what it means is this inferior lateral pterygoid muscle, in order to protrude the mandible, the inferior lateral pterygoid muscle has to contract. So it contracts and it brings the condyle forward. Okay. Well, when it brings the condyle forward, within time, this can develop what's called a myostatic contracture. Contracture, not contraction, contracture. What does that mean? That's the painful shortening of the functional length of a muscle. All muscles do this. If muscles aren't functioned to the full length, they actually, if they're not allowed to go to the full length, they'll actually functionally shorten. If you break your jaw and have your teeth wired together for 6 or 8 weeks, they take the wires off. You don't open 40 millimeters. You open like 5 or 6 or 10 millimeters. Because what happens is the Golgi tendon apparatus send messages back to the muscle spindle saying, hey, I'm not being tugged on here. And the muscle spindle shortens until there's a tension in there. And so what happens then is that muscle functionally shortens. So if you bring the jaw forward like this and do not allow it to come to advance back into the most musculoskeletal stable position, you are at risk sometimes to develop a myostatic contracture of the inferior lateral pterygoid so that it is temporarily shortened. Now, I mean temporarily. If it's a myostatic contracture, this is reversible through what's called the inverse stretch reflex. You start to lengthen the muscle and it comes back. Just like if you broke your jaw, if you tease that, give a little pull, the Golgi tendon apparatus feels that, it tells the muscle to relax, and you're lengthened back slowly over a number of days or weeks. But what if you didn't do that? Okay, what if the patient didn't grow? And you see, you take the appliance out now, and the orthodontist says, hey, we're going to finish the case here in this forward position. But they don't know it's a forward position. They think it's musculoskeletal stable. If that happens to the patient, then now the condyle is actually being braced in a more forward position to maintain the orthodontic occlusion that has been established there. Okay, so here's the condyle down the posterior slope of the eminence a little bit, and the orthodontist has developed the occlusion into this position. So now we do not have orthopedic stability. We actually have occlusal stability, but a condyle is not in a stable relationship. But let's just say that the 14, 15-year-old finishes the ortho and goes out. And now a couple years later, they come back to the orthodontist and they say, doctor, I've got a problem. Because if these muscles decide to start changing, if these muscles start to re-lengthen to their musculoskeletal stable position and go back into the musculoskeletal stable position, what's interesting, of course, the other end of this bone of these teeth, and what they do is they open up. And now the patient develops an open bite. And so what happens is they walk in at age 16 or 17 or sometime and say, Dr. Orthodontist, here's the bite you gave me. Here. But look what I got now. I got a bite here. So they got two bites. They got a dual bite. They got the bite the orthodontist left them in, and yet they can go back further, and now they have an anterior-open bite. And this is one of the biggest fears of the orthodontist, because the student, the patient comes back and says, Doctor, I don't want to do any more ortho, but I got to have this bite fixed. And the orthodontist looks and says, oh my goodness, is this now orthodontic surgery? It's certainly a lot more ortho. So the question that I would propose to the orthodontist, before he or she finishes the case, if he's using a functional appliance, he needs to assess for condylar stability before finishing the occlusion. So if the condyle is truly down the eminence, he knows about that or she knows about that, and they can make that correction. So what are some considerations? I would recommend the first thing the orthodontist try to do after the functional appliance is to try bilateral manipulation. We talked about it earlier, the last DVD, where you can put the hands in there, seat the condyle with your fingers, with bilateral manipulation, and see if that condyle can be there. In few patients, if you have not really developed a myostatic contracture, you can find that position and all of a sudden put the condyle up there and then bring your teeth together and go, whoa, this condyle didn't grow at all. It's just been postured forward. I need to make sure that I've developed the teeth in the right place. Unfortunately, though, if it's truly a myostatic contracture, it doesn't lengthen that quickly. And therefore, you may need a little bit of time. So one of the things that I would recommend to an orthodontist who has had a patient in a functional appliance for quite a while is to consider an anterior biplane for a very short period of time. You're talking about 2 or 3 or 5 days, maybe a week, because that's all it's going to take to let that condyle reseat to its musculoskeletal stable position. And if, in fact, you put an anterior biplane in there and there's been no shifting of the mandible, probably you got growth. But if you put it in there and all of a sudden the mandible goes back further into its more musculoskeletal stable position, you got to relook at what it's going to take to get the teeth in that position. Now, you can do that by placing a little stop on the front here, so that when the mandible closes and they only hit that stop and there's no posterior tooth contacting, what's going to happen is the condyle is going to be seated to its musculoskeletal stable position with just this little bitty anterior biplanar stop. And one of the things you can do, this is called a quick splint. And quick splints are pretty easy. You can take one of these little quick splints. It's a custom. It's a generalized. It's a little piece of plastic will fit over everybody's anterior teeth. Put it in a little impression material. Put it over the anterior teeth. So you still got the braces in place. And now the patient closed. You can adjust it so that the teeth will contact back here. And you give them a week or so wearing this appliance and see if there's been any shift in the occlusal position. What else could you do? Well, sometimes you can carefully consider imaging. Because if you took a tomography of this patient and it looks something like this, and now you're finishing with your functional appliance and it looks like this, I mean, it's pretty obvious to me this is not likely to be in a musculoskeletal stable position. Now, I'm going to say something in a second about radiographs. You got to be a little careful with radiographs. They're not always what you think. But if it's that far out, you'll know about that. Now, what's the other thing that we will sometimes use? And another reason why we will have mandibles brought forward. What about painful disc displacements? What you'll hear from me in a series of lectures when we get into treatment of TM disorders, that there's certain patients like intracapsular, very specifically disc displacements with reduction, that if you bring their jaw forward and take them off the retrodiscal tissues, they can have some pretty good pain relief. And so if we have a situation where we have a disc that's displaced or dislocated, and you see the retrodiscal tissues are now inflamed, and that's painful. If we bring the mandible forward, we can put it on the intermediate zone of the condyle, take it off the retrodiscal tissues, and very quickly, you can have a good reduction of pain. Therefore, the question has to be asked is, then does the mandible have to be maintained forward forever? And I'm going to answer this really quickly, but I want you to go to our lecture that we're going to do on this specific treatment later with more detail. Because it turns out that, in fact, the retrodiscal tissues can adapt. And once they adapt, they can develop dense fibrous connective tissue. And when that occurs, the condyle can be brought back into its musculoskeletal stable position, and now we have tissue, like new tissue, connective tissue, almost like a callus, that can be loaded without pain. Now the disc is still displaced. We may still have some clicking, but we can load this now without pain. And when we get into the management of intracapsular problems, we'll start to really emphasize the fact that our treatment goal is to be reducing pain. Maybe not necessarily get rid of the click, because get rid of the click is very difficult to do. So in the realm of intracapsular problems, yes, mandibles can be brought forward, and they can be left there for a little while till tissues reduce, repair, and then put them back into their normal position. Another appliance that we're using a lot more in dentistry right now is sleep apnea appliances, which bring the jaw forward. And some of these patients you might see, if you're working with sleep apnea patients, they might develop a posterior open bite, secondary to posture and jaw forward through what I believe would be myostatic contracture. And so you have to be watching these patients that they start to develop a little posterior open bite. You may have them getting in the morning and do some exercises to re-lengthen the lateral pterygoid muscle. And that may be useful. Okay, so that was the anterior protrusive position. What about the 4-7 radiographic position? Well, the 4-7 radiographic position was first developed by Dr. Gelb, Harold Gelb, out of New York. And this was done way back in the early 70s. And at that time, Dr. Gelb said that we think we can look at the jaw joint and take a picture and measure what would describe on a grid a 4-7 position of the radiograph. And it would determine the best ideal position of the condyle. At that time, what we had is transcranial x-rays. And this is a transcranial x-ray. And you get to see, you look at these, say, okay, here's the condyle. Oops, I'm sorry, here's the condyle, there's the fossa. This is where the disc is, the discal space. And a grid can be placed over that. And the grid can be numbered. And then it would say, okay, where the condyle should fit is right there in the 4-7 fossa. You can see this condyle would be too far back. Okay, so basically, in my opinion, most of these 4-7 positions are in a slight anterior position because that would bring the condyle down more. So if you look at this slide, this is a picture of the condyle. There is a grid that laid out. There are the 4-7, or there's all the numbers that are placed in the grid. And here, this 4-7 box is where the mandible would be. Therefore, if you take an x-ray and you see your condyle is behind that, then you say, well, the treatment would be is to bring that condyle forward into the 4-7 box. That's the concept of that. Well, let's take a look at that. The 4-7 position assumes that the radiograph of the temporomandibular joint reveals an accurate condyle-disc relationship. And that certainly is not true. Especially not true for transcranial films. Now, I realize that transcranial films are a thing of the past. It was something that we used a lot when this was developing through the 80s and the 90s. We don't use it anymore, but let's look at this. Here is a transcranial film. And when you take a look at that picture, what you're seeing right here is there's the condyle, there's the fossa. And it's really easy to think, okay, this is the articular surface of the condyle, and that's where the disc is and fossa. The problem is that's not true. Because this is the articular surface all the way around here. This is the medial pole, that's the lateral pole. Medial pole, lateral pole. Okay, so in other words, the films are coming across the cranium to the opposite side. So you're going to take this x-ray, you put a film on this side, take an x-ray this way through the cranium, because otherwise you're going to get two condyles. You can't do that with all the sinus and bone. So you come across, and what it does, it distorts your image. So if you take a look at this space right here, if you look at that right there, what is that? That's the lateral pole of the condyle. What's this up here? That's the medial pole here. See, the articular surface of this condyle is really right under here, as depicted here. Here's the important part of the articular surface, not this at all. In fact, if you look at the space that's here, that we spent a lot of time looking at, the space is here, which is the lateral space, the space in the most lateral part of the joint over the lateral pole, which is the least likely to be actually articulating. Because when a patient goes side to side, it's going to come down the medial wall. It's not going to go out so much, just a little bit out. That's the side that just rotates. And well, let me just share with you what I did in my very first textbook, which was 1985. I wanted to see if this concept had much merit. So I took a picture of my own condyle. This is my condyle right here. I think it's my left condyle. If you take a look, here is the space. Here's the condyle. It looks like it's pretty centered in the condyle. It looks like that's a very nice place for that condyle to be, so I'm kind of lucky. However, they took that film, and then when the radiologist went out of the room and came back again, I said, take another one. He said, take another one for us. I said, just take another one. So he shifted the film, took a second picture. When he was turned around and going out before he took the picture, I moved my head about 7 degrees to one side. And this is the picture that showed up. So a 7-degree movement to one side shows a condyle, which is no longer a central fossa. This looks like that condyle is too far back. There's not much space back here. Which means if I took this picture, my condyle's in the wrong place. I need to bring my jaw forward with some dentistry. If I took this picture on the other side, I'm sorry, I would be fine. Well, what my choices was, I had a choice to have my mouth reconstructed orthodontically like crown and bridge, or I could just move my head 7 degrees to one side. Well, I decided to move my head 7 degrees to one side, and I'm still nice and healthy even today. What is the message? The message is you cannot take a transcranial film and look at the position of the condyle and shed any meaning on whether that's too far forward, back, or where. But nowadays we're using tomography, and tomography certainly is a far more accurate way to look at joints. And you can section that joint right down in very specific patterns of 1 millimeter or 2 millimeters. But what you need to appreciate with any film is that it's going to reveal our subarticular bone. So when you look at this section, although it's far more accurate to look at that, the soft tissue is not being seen. And the soft tissue may be very important because the thicker the soft tissue, the wider the disc space. And disc space has something to do with where you're assuming if this condyle is in the right position or not. So let's take a look at this. This is an anatomy of the joint. What are you going to see? What you have here is, this is the articular disc, of course, and the articular disc is soft tissue, which will not show up in tomography. And then what do you see? You see a lining. This is soft tissue, and it's also the lining because the articular surface of that joint, is dense fibrous connective tissue also. So you're going to miss this. What you are going to see is subarticular bone. So if you took an image of this joint, you say, okay, there's our subarticular bone. Let's image this joint. This is the loading factor. This is where you're going to see what we talked about before with the masseter, medial pterygoid, and temporal. It's going to seat the condyle this way into its musculoskeletal stable position. Now, you look at this and you say, well, this looks pretty good because what we like to see is symmetry. We like to see equal amount of space on either side. See, this is another problem we have. Dentists really like symmetry. People like symmetry. And so when you see something that's not symmetrical, the tendency is for us to say, whoa, there's something really wrong with this patient. So therefore, we got to make some corrections. Symmetry is not necessarily, no one is perfectly symmetrical, but it does feel good to have symmetry. Now, let me show you something else. What if you had a patient had this kind of situation, where what they really have is it's a little thinner in this area here. Even though the forces are directed through the musculoskeletal system are this way, the disc is a little bit thinner here. Because actually in some cadaver specimens, this has been shown to be just 1 millimeter thick right on the articular surface, on the intermediate zone. Well, let's take an image of that. Oh my gosh, if you took an image of that and you measure joint spaces, you say, whoa, this condyle is too far forward. This condyle needs to be pushed back. This is an anterior displaced condyle. That is not true. This condyle is in a very nice musculoskeletal stable position. You just can't image the soft tissue to determine that. Well, let's do something different. What if it was really thick, this area here, and it was thinner back here, but the forces of direction are still musculoskeletal stable right here? And you took this image, and what do you see? Oh my gosh, this condyle is too far back. This is a posterior displaced condyle. No, it's not. This is a normally positioned condyle on the musculoskeletal position, but the soft tissue is not imaged. You see, what you have to appreciate is that you can't image a joint and know what's the most functional position of that fossa, or of that condyle. So, conclusion, radiographs are not an accurate method of assessing a functional joint position. They're not at all. X-rays are wonderful to detect arthritis, tumors, things that are going on like that, growth, things that are going on in the joint, but do not rely on a radiograph to determine what's the best functional position of the temporomandibular joint. Which leads to the 5th joint position, which is what's called the neuromuscular position. Let's think about neuromuscular position. This is a technique that utilizes a concept that should determine the most orthopedically stable relationship with the condyle and the fossa. That's what this whole philosophy is. And the concept goes something like this. What the operator will do is he or she will put an electrical device onto the area of the temporomandibular masticatory system, let's say, because it's not over the joint, and it's going to stimulate the muscles to contract. Okay, and it might stimulate, so every second and a half, the muscles are going to pulse. Well, the concept is that this pulsing is going to relax the mandible and put it into a, quote, rest position. So when you take it off, the mandible just drops down. Now, there are some that believe that when this drops down, this condyle will actually come away from the fossa. You'll have separation between the condyle, the disc, and the fossa. Remember we said earlier in the anatomical section, we said that condyle must always be against the disc, against the fossa, because that's orthopedic stability. You stabilize it. And nature's not going to let a condyle dislocate by just relaxing the jaw. There's always going to be enough synicity to keep that condyle against the disc, against the fossa, because that's an orthopedic principle. There must always be close proximal contact between articular surfaces of every joint all throughout the lifetime of the patient. So what happens is that you really don't have, this is the orthopedic principle. Articular surfaces of all joints are maintained in close proximal contacts at all times. If you separate those, you have by definition dislocation. Nature isn't going to allow your joints to be dislocated by just relaxing your muscles. Okay, so what can happen is this though. If the muscles are pulsed and the patient is asked to relax, what can happen is the mandible can in fact drop down. And so what you'll probably see is a little protrusive movement here and a rotational movement as the mandible drops down into a more relaxed rest position, if you will. So what is this? This is a gravity-assisted position. It's not a musculoskeletal stable position. It's not a ligament position. It's not a muscle brace position. It's not a radiographic position. It's actually a gravity-assisted position. Because as you pulse the muscles, if they relax, the gravity is going to let the jaw fall down here a little bit like that. So what happens is we talk about a thing called the rest position. The rest position, now by definition, rest position means lowest EMG activity. So if you let the patient just open the mouth and rest, what you'll see in most of the studies is that you're going to have anywhere between 8 and 12 millimeters of space between the teeth and 2 to 4 millimeters forward. These are some of the studies where you looked at EMG activity. See, rest position is the least amount of electromyographic activity. If you want to see the rest position, you can go to a nursing home. You can go on the summertime when you see some of the old gentlemen sitting in rocking chairs on the porch and they're sleeping. And where's their jaw? Like that. It's open. Because what rest position really basically is when gravity equals the resistance of the soft tissue that's holding it up. And this is called viscoelastic tone. When these muscles relax, they're not going to fall, you're not going to fall all the way open. It's going to stay there until there's some elasticity with the tissue that you have. So that's true rest. True rest means the least amount of EMG activity coming out of the elevator muscles. Now, here's a whole group of studies that look at these and show the rest position to be pretty wide open, 11, 10, 12 millimeters, things like that. Now, the postural position is something different. The postural position is the position by which you keep your jaw in readiness to function, which is not 10 millimeters wide open. It's a couple millimeters, right? It's just letting your jaw relax, anywhere from 1 to 3 or 4 millimeters, depending on the study you look at. So when you make those set of dentures and you ask the patient to speak, I go to church on Sunday, Mississippi, you don't want those teeth to touch. When they're saying those, there's got to be a little air. That's the postural position, not the rest position, the postural position. It's where your mandible is posturing in readiness to function. Now, in the neuromuscular concept, they pulse the muscles, bring the jaw more forward like that. And then so there is some room there for your teeth to function. They add that 1 to 3 or 4 millimeters, and they say this is the place this patient should be. This is the myocentric position. And then they'll make an appliance, which is a myocentric appliance, is fabricated in this position. So pulsing the muscles, let the jaw relax, come across, close a little bit more, and build the appliance. Okay, so what's going on from the condylar standpoint? What's going on from the condylar standpoint is that you see that this condyle may rotate a little bit and come forward. I think most patients in a myocentric position have a little bit of rotation and certainly, a little forward and a little certainly the rotation that occurs. Here's a typical appliance that's made in the myocentric position. So you'll see they're relatively thick. The patient has been given an occlusal scheme so they can bite into that position because it's not going to be determined by the joints, it's going to be determined by these teeth, like that. Here's another one. You can see how large this is and how the jaw has been brought open a significant amount, and it has a lot of occlusal form to it, requiring the patient to be in this forward position. So why would you use concepts of neuromuscular dentistry? That'll be the question you have to ask yourself. Okay, so somebody comes to you and they propose, I'm in neuromuscular dentistry, I want you to join my club. Why would you do that? Well, first of all, because relaxing the muscles sounds pretty good, doesn't it? I mean, they say, well, because we're going to relax the muscles. And how could you fight? How could you argue that you want muscles to be relaxed? And I'm going to put the muscles at rest, which is something else that you want to do. And I'm going to let the muscles determine the jaw position. Well, what I said before with musculoskeletal stable position, sometimes we can use muscles to find a stable joint position. These statements are all sound logical. But the question you must ask yourself as a treating dentist is, are they really true? Or are these just logical things that are said? So let's just take a few minutes and talk about how neuromuscular dentistry is actually accomplished. First of all, a device, this is the monitor, is placed over the jaw system, and low-volt galvanic stimulation occurs, and the muscles are pulsed about every second and a half. The patient may wear this thing for anywhere from 32 minutes to an hour to, quote, relax the muscles. Then what happens is they put electrodes on the face to record EMG activity, to report is the muscle activity strong or weak. And then they have a jaw tracking device, which means the jaw will, anywhere the jaw moves, they can determine exactly where that is. And then there's a way to record joint sounds, and they can see whether the patient's clicking or popping. Well, what's interesting, all of these instruments are very exciting to the dentist because we dentists like instruments. And so what you see is any of these things are intriguing to us, and they look complicated, therefore they must be accurate and stuff like that. And they certainly are impressive to the patient. I mean, the patient walks in the operatory and sees this and says, oh, doctor, this all your stuff? Yes. Oh, do you know how to use this? Oh, this is how I do my dentistry. So you have this impressive thing that's going on there that you have to be careful. Because what are these instruments going to do? Well, they could offer some measurability, and which is needed for research. We have to do better understanding. We need to do better developing ways to measure patients, because it's through measurement that we can understand more about science. They do offer some measurability. But what we really need to basically ask ourselves are some questions. Before you use any instruments in dentistry, you got to ask the question, is it valid? Is it really recording what they say it's going to record? And that's pretty standard. So is it recording jaw movement? Is it recording muscle activity? Is it recording clicking joints? So the first thing is valid. Is it an instrument that does say what it's supposed to say? So that's the first question we have to ask. The second question is it reliable? See, it can be valid. It could be actually recording joint movements and stuff. But the question might be, is it going to be able to be reliable? Can I use it and you use it and try it on Betty and Mary and Sue? And does it come up with the same information? That's reliability. We need that. So the next question has to be, is it reliable? And there's ways to test instruments for that. But if you're going to use an instrument not only for testing like this, but also from a diagnostic standpoint, then it also has to have two more characteristics. And what those characteristics are, it has to be sensitive. It has to have sensitivity. Sensitivity is the ability of the instrument to determine who's sick. So if I had 100 people in a room and 75 had TMD and 25 did not have TMD, how well will this instrument tell me who are the 75 people that have the TMD versus the ones that don't? That's called sensitivity. If I can pick out every one of those 75, then I have a score of 1, which is an enormously powerful sensitivity. Okay, that's called sensitivity. The next thing that has to happen is you have to have specificity. Specificity is the ability of the instrument to determine who's not sick. If I have 75 people in the room with TMD, 25 don't have TMD, how much can the instrument tell me who does not have TMD? You see, there's some instruments that have sensitivity and poor specificity and vice versa. And so you have to be able to understand which one you need. Now, if we're going to be dealing with something like cancer, which has a high mortality rate, then you want to know any chance this could be. So you want a high sensitivity, and you might actually get some false positives in there until you test them out. But you'd rather have false positive. You don't want to miss anybody. But when you're dealing with something like musculoskeletal pain, which has a relatively transient kind of stuff, and it has a lot of self-limiting features to it, which we're going to talk about later, is you don't want an instrument that says sensitivity as well as you want something that says specificity. Because if it's sensitive, every time you put it on a patient, it's going to show they're sick, and they may not be sick. they may actually be pretty healthy. And here is, in fact, what's probably going on right now. Much of the standards that have been used for these equipment would suggest that most people put on these instruments and they're not in the place they should be, they're not in the right job position, and therefore they're really sick, when in fact they likely are not very sick. Now, once an instrument has shown validity, reliability, sensitivity, and specificity, that's a time that you can collect the information. But you still have to ask yourself the question, does the information you have therapeutic meaning? Does it really change the way you treat your patient? It may not. It may be just a lot of fancy instruments but not change the treatment. Or it could change it drastically. You see, we dentists are looking for instruments all the time. Our cardiologists have EKGs and they look at. Okay, that's something that they can measure. We're looking at instruments, and yet we have to ask ourselves some questions. Do we have these instruments at this time? Well, let's go back and look at low-volt galvanic stimulation. Does pulsing the muscles reduce muscle pain? That's the first question I'd ask. And the answer to that is yes, it does. Physical therapists have been using high-volt galvanic stimulation for a long time. And they'll pulse muscles, and it's sort of a tendency to quiet the muscles, relax the muscle, reduce muscle pain. So it can be useful, to reduce muscle pain. Does pulsing the muscles lead to a jaw position that has usefulness in dentistry? Oh, that's a better question. So if I pulse the jaw and I get the muscles more comfortable, what if can I take this position and assume they're going to stay comfortable from that point on? Here's actually the bottom line. We have no well-controlled clinical trials that substantiate that this position, that when you pulse in, is stable, functional, or even a good treatment option. We have no data on that. So we've got to ask ourselves the question, is this going to be really helpful in treating our patients? Just because the muscles are less painful in this position does not mean that that if this position were a permanent position of the jaw, you'd have no pain. We're going to talk about this later when we talk a little bit about vertical dimension. You know, the fact is that if you get somebody comfortable and then you go out there and make an appliance and you think, okay, they're comfortable now. If I build the teeth in this vertical, they'll stay comfortable. That's not necessarily true at all. Muscles like to be moved and functioned. And therefore, this concept is one that we want to buy into it because we have a very mechanical brain in dentistry. But yet, when you look at vertical dimension, it's far more versatile than that. We'll talk about that one later. What about EMG recording? Okay, so the first question is, can you find a rest position? Sure, you can find a rest position. That's the least EMG activity. Or wait a minute, are you really looking for the postural position? You know, or are you looking for the myocentric position? You got to ask yourself these questions before you start pulsing the muscles like that. Now, we have no well-controlled clinical trials that support the concept that the jaw functions in a myocentric position. I didn't say it can't function in that position. I just said we haven't got any data that says it's better in this position than someplace else. And yet we're making that assumption sometimes. Using EMG to diagnose TMD. Okay, I'm going to put these electrodes on the face, and I'm going to see, as you can see in this corner here, this high level of activity and this low level activity. So boy, it looks like the patient moved from pain to no pain. Well, here's something that we need to appreciate. And once again, we'll talk more detailed about this when we get into muscle pain. There are actually no differences in the resting EMG activity between pain patients and controls. And this is done multiple times. You'd think that, okay, patients with muscle pain, these muscles are contracting, and you see higher EMG. That is not true. The vast majority of patients that come to you with muscle pain do not have hyperactivity of the muscles. There are no differences in these patients. We've done studies ourselves, and I'll show you some of the studies when we start talking about muscle pain. It may be logical, it's just not true. Therefore, EMG, difference in pain patients and controls, there are no differences between pain patients and controls. Yet, in an individual patient, EMG activity will increase in the presence of certain events or certain things like pain. If I have EMG on my masseter muscle and I put the patient in pain, you know what? We're going to see a slight increase. If I put emotional stress on them, we're going to see slight increase. This is called protective co-contraction. We've already said a little bit about that concept. We'll show more about that when I talk about muscle pain. So there's a variation in this when you place people under stress or if they're in pain. Look, are EMG recordings reliable between patients? Well, here's the thing. This is wonderful technology if you control variables. EMG recordings are significantly influenced by such variables as the sex of the patient, the age of the patient, skin thickness, fat faces and thin faces, skeletal morphology, chronic bruxism, even emotional stress. all those variables change what EMG is coming out of the muscles. And therefore, if you're going to compare Betty and Bill and Sue, you need to control all those variables, which are not easy to control. You say, well, therefore, we can't compare EMG activity between different patients unless those variables have been controlled. You say, but what about comparing EMG within the same patient? Well, I'm only going to put this on Mary, and I'm going to see her 2 weeks ago, and next week, and the week after, and see if they're getting better. Well, there's variables even within a patient that you have to control. Placement of the sensors directly over the muscles. You know, a half a centimeter of movement off a masseter muscle will decrease the EMG activity by 25%. So it's got to be right in the same place. It's got to be oriented the same way. The distance between electrodes have to be the same. There's crosstalk between other muscles, muscles of facial expression. We've learned that patients who have pain, they wrinkle up and they get more EMG because they're getting muscles of facial expression in there than not pain. So these variables are so great, you have to control them. And if you don't control them on each time you see the patient, you can't compare yesterday's with today's and with tomorrow's. Because over time. Now, if you're a research person doing EMG, you get a template over the head. And you can put a little dot every time. So you go right back to the same place for the electrode. And you're at the same patient. So other variables are controlled. Is that being done in a clinical practice? No, it's just being placed on here. And we're assuming the data is accurate. See, the gold standard must be applied too. You have to look at a gold standard for all general populations. And the gold standard would be, an EMG of such a level. Well, that's not been determined either. There's a couple of papers out that have set a level of which most people are above, which again suggests that most of us are sick. And you got to be careful that we don't overdo that. What about jaw tracking devices? Do we have any jaw tracking devices that can measure joint movements? Oh, yes, mandibular movements. Are these instruments valid? Yeah, they are valid. When you use correctly, you can record exactly how the jaw is moving from side to side and forward, open, and closed. Are the instruments reliable? Well, that likely depends on the patient and the disorder and maybe the doctor. But if they're consistently used the same way, yeah, you can probably see the same kind of activity, so they might be reliable. So the next question is jaw movement different between TMD patients and controls? And the answer is, absolutely it is. Yes, there are differences. In patients who have pain, the jaw will move slower and there'll be less movement, restricted, because that's what pain does. Pain limits how far you want to move the system. Okay, if I have tennis elbow, I'm not going to sit around and move it a lot. I'm going to move it a little bit because it moves slower and it's going to have some restricted movements. However, any source of pain input can cause these changes in jaw movements. And the normal pattern of movement returns once the pain resolves. So if you had a toothache, you have limited mouth opening and it's going to move slower. If you have joint pain, same way. Muscle pain, the same way. Even probably pain referral, which we'll talk about later, the same way. And it doesn't matter what kind of pain you have. You will see this. So if you're trying to determine whether you're going to get some usefulness out of jaw tracking, if the patient has pain, you're going to see positive findings. Therefore, just ask the patient, do you have pain? Yes, I have pain. Okay, then you can expect to have limited, slower movements and more restricted movements. The patient says, well, I can see the click. You can see the jaw move during clicking. Yes, you can, but you can see that and you can feel that. You don't need a sophisticated instrument to determine what that is. What about joint sounds? Are these instruments valid? Yes, they're absolutely valid. You can put these on here, and if they're used properly, they will record joint sounds. Okay. Are these reliable? You know what? They are reliable. The instruments are reliable. You put them on here, they record joint sounds. But, however, the patients may not be reliable. Patients will click in the morning and not in the afternoon, or they'll click in the afternoon, not in the morning. Clicking will come and go during different times. Joint sounds will change by the hour, by the day, by the week. We have lots of data to show that people click off and on, off and on, off and on. So the question you have is joint sounds are not significantly related to pain. They're not. Although we've convinced ourselves they're not related to pain. Most often they're painless in most patients. And they can change in any single visit over time. So the question is, how are you going to use the information that you get from the treatment? What are you going to do with that data that says it clicks or doesn't click and you treat the patient? That is a problem we have. Okay, does the neuromuscular position offer orthopedic stability? We've talked about orthopedic stability in a couple of our lectures. So let's talk about this, a gravity-assisted position. The jaw drops down, open. Is this reproducible, is the question you have to ask. We need to study that to see if it's reproducible. Since the mandibular position is determined by muscle relaxation and gravity, anything that influences one or both of these could affect the jaw position. All right, well, what do you mean by that? What about head position? If you had the patient sitting up like this and having pulse, what if you had him come like this and having pulse? Put back like this? What if he went to the side, pulse? I'd expect the jaw to be in a different position because gravity is going to pull that way. What about deep pain input? In the presence of pain, these muscles are contracting. And therefore, you're going to have a different jaw position if the patient has pain. What about emotional stress? We've demonstrated in our lab, and I'll share with you later, that if we put people under emotional stress, we see increase in tonicity of elevator muscles. And what about other factors that we're not even sure about any longer? And then what about this? What about reproducibility over time? So let's say you pulse the muscles, you find a myocentric position, and you reconstruct the mouth there. Once you call them back in 6 months, and you try the same pulsing, do you find another position? If you do, then how can you say the other position was so important? See, all of these studies need to be done to understand about this. So the summary, in my summary of neuromuscular dentistry, it utilizes elaborate technology, very impressive to the doctor and the patient. It does provide some measurability, therefore we can use some of that equipment maybe, if we use it correctly, to get some very good basic research about jaw function, muscle function, clicking, things like that. However, all these instruments may not be valid or reliable, and in instances when the data are reliable or valid, we need to better understand how this should influence our treatment. Okay, so here's our concept. The concept of joint position. There's the 5 we just went through. So which condyle position is correct? Which condyle position is correct? Well, you know, this is a tough one. And I'm looking now, and this has been going almost for 1 hour, so I think you need a break. So what I would like to do is stop this lecture, and we're going to start a second part of this right at this point. And we're going to go through which one of these is correct, and which one would you want to select to do dentistry for your patient. So let's just stop right here and take a breath, and let's get you back, and we'll have a second lecture where we'll complete this topic on which one of these 5 positions would be the one you'd like to select for your patient.